Good morning. Can everybody hear me okay? I'm getting thumbs up. My name is Monica Ogelby. I'm a pediatric nurse practitioner who has been in this role for about a year, and I'm joined here today by Lavallee, who's from CSHN, who is one of the lead nurses over there and also is in charge of the Pediatric High Tech Program. So we wanted to take a little bit of time today just to tell you a little bit about not only the new Pediatric Palliative Care Program that's available within many counties throughout the state, but also to talk about the High Tech Program, and then sort of on a larger scale, CSHN and some of the changes that are happening over there, and most importantly, how the Palliative Care Program and CSHN and the High Tech Program and all the CSHN programs and palliative care are interfacing really directly. We fall under different roofs technically, different departments within the Agency of Human Services, but we work very closely together on a daily basis. And then sort of our last objective is really to obtain some feedback and some thoughts from you, the people in the community, parents, advocates, caregivers, providers, whoever you may be and whatever your role is. We're always looking for feedback on how we can make things better for children and families in the community. So we're going to start by doing today is to talk a little bit about what palliative care is. This is a hot topic. I think there are a lot of barriers to accessing palliative care just because people don't always understand what palliative care is. The way that I like to explain palliative care is sort of that asterisk first line right there on the slide, an added layer of support for children and adolescents living with serious illness. Now, of course, we're talking about a pediatric-based program, but of course, this can sort of apply to anybody at all ages and all stages of life. And you will notice that there is no dying and there is no hospice mentioned in this definition. Palliative care is not hospice, and if there's one thing that I will say over and over again, it is that palliative care is just a way of supporting people who are living with serious illness, and so it makes sense that within the hospice world, palliation and palliative care has always been a huge part of that, and that's why hospice is so successful and so wonderful and so well received by families and patients. But what we really are intending to do within the palliative care world is take away that hospice barrier, that 6-month determination of life, and make supportive services available to anybody at any stage of illness who could use some supportive services around their illness. And what also makes palliative care so extraordinary is that it really focuses on what your goals are as parents, as a child living with this illness, and making sure that those goals are really at the heart of everything that we do. It is available at any age and any stage of illness. We okay? And it can be offered along other treatments your child is receiving. So for those of you that are familiar with the hospice model, you may be aware that historically when you elect to be on the hospice benefit, maybe a physician has said that we really aren't sure that you're going to live beyond 6 months. And so what that might mean is in order to get all of the benefits of hospice services, you forego life-prolonging or life-extending treatments. That is absolutely not the case with palliative care, and actually it's not the case with hospice care for children anymore, thanks to the Affordable Care Act amendments that were made by President Obama in 2010. So with palliative care, it's adjunctive. It's going along with everything else that you're doing within your treatment plan for you, for your child, and it's just meant to be, again, an added layer of support. So how can palliative care help? It can help with challenging symptoms like pain, nausea, sleeping problems or fatigue, loss of appetite, all of the different types of emotions that can come along with living with a serious illness like depression, fear, anxiety, decision making. That's a huge one. We work with so many families that are constantly given sort of this buffet of choices on how to best care for their children. And it can be very, very overwhelming when, say, you're facing a decision whether or not to consider a tracheotomy or to consider BiPAP or CPAP. Lots of different decisions are offered to us now thanks to wonderful medical technology, and sometimes they're really hard to navigate. And providers, despite their best efforts, sometimes aren't the best at helping families make those decisions. So palliative care can be a really, really wonderful service in that sense. We can help you with simple things like managing your child's health care. It's very overwhelming. I know a lot of parents that are better nurses and case managers than people that do that for a living. Planning for the future. What's that going to look like for your child and for your family? Sibling and family support. We see a lot of siblings that not for any reason in particular, but just by virtue of the fact that they have an ill sibling, that just need a little bit of extra support because so much attention is paid to that child who might be living with illness. And then also caring for your child at home. It's not to say that you cannot bring your child to the hospital or that you cannot access resources outside of the home, but we do know that there are a lot of families that just by virtue of the fact that they don't have support in the home often have to end up going to the hospital or to the emergency department. And so one of our goals and objectives is to make sure that we're providing more services for kids in the home so that they can stay there as long as they want to. Pediatric palliative care specifically is sort of a new world, and there is a lot of evidence that's just starting to pop up about palliative care. Some of the evidence that really is a proponent for palliative care includes things like reducing suffering and distress, improving communication, addressing needs of families and caregivers, similarly to what we talked about before, ensuring that the goals of the family are really at the center of the care plan, reducing unwanted, unnecessary, and sometimes painful interventions, improving satisfaction for the families and for the child, improving quality of life while reducing costs, decreasing risk factors associated with complicated grief. And for those of you that aren't familiar with complicated grief, that's something that happens to families that are in the bereaved period after they've lost someone that they love. And if they're grieving and their bereavement period doesn't allow for them to process their emotions appropriately, sometimes we see long-term comorbidities, things like cardiovascular disease, anxiety, substance abuse, depression, and these are all things that with appropriate palliative care interventions we can sort of help support families and hopefully prevent. And then of course the biggest thing here is improves survival. So one of the wildest things about palliative care and actually about hospice, frankly, is that people that are accessing these services and have palliative care or hospice care as part of their care plan live longer. It's an amazing phenomenon, but what we're seeing is that when people get the support that they need, they do better. And so again, this is a further proponent for us to sort of make palliative care much more accessible and much more accessible for families in the community at an earlier stage. So this slide here talks a little bit about, I won't go into the details of it, but it talks a little bit about historically how we've viewed curative care versus palliative care. So in the top one, number one, incompatible domains, you can see how, and you've probably experienced in your own lives where when someone is diagnosed with an illness, so at the bottom there's that arrow that sort of talks about time trajectory. Someone's diagnosed with an illness and we say, okay, you're diagnosed with, let's use cancer as an example. We're going to do chemotherapy. And then we go a long time and we realize that chemotherapy didn't work and we still have cancer, so we're going to do another chemotherapy. And time goes along and it's not working. Okay, we've tried all these chemotherapies. Now we're going to introduce palliative care because chance of survival appears to be less. So obviously that's incompatible, and that person from the time of diagnosis is not getting all the benefits of those supportive services of palliative care, and also they're associating palliative care with more towards end of life, which makes perfect sense as to why many of us still struggle with what is palliative care and misunderstand how palliative care can be effective. The second diagram here talks a little bit about competing domains. So we've got a diagnosis at the beginning of time there, and maybe we introduce palliative care, but we really don't implement it. And we only implement palliative care as chance of cure or survival decreases. So the third visual here of complementary and concurrent components of care is the one that we're really trying to push now. And the takeaway from this is that palliative care is most effective for everybody involved, the care team, the child, the parents, the family and friends, if it's introduced at the time of diagnosis, because it's just support. It's support for the care team, it's support for the family, and the idea is that if it's introduced early on at the time of diagnosis, then we can actually ride out those highs and those lows of illness with you, and that we're not scary and we're not about end of life, we're about fostering life and being proponents for life. And if anything is to happen and if we cannot find a cure for an illness, then we are there with you through that. But as we know with children, they are very tricky and they surprise us, and there are so many times when they might get so sick and we're not sure that they'll pull through, and they do, and then they have a multitude of amazing years and then maybe they get sick again, and we're worried that they might not pull through again. And then they have another few wonderful years. And kids are just absolutely amazing and resilient. And so generally speaking, palliative care is best started nice and early so that we can ride through all those highs and lows with you, add supportive services when we need to and where we need to, and then back off when your child, your daughter, or son is at school and living life and loving it. So where did this whole palliative care program come from in Vermont? It was really a product of some wonderful, wonderful families and a physician here in the state who got together and talked to the Vermont legislature in 2009 and 2010 to ensure that we were going to allow access to these services to kids. It was in 2010 that parents testified before the House of Human Services Committee, and the legislature instructed the Department of Vermont Health Access to request a Medicaid waiver. Department of Vermont Health Access, for those of you that aren't familiar, is actually Vermont Medicaid. It's essentially the same thing. And so in 2011, our global demonstration waiver here in Vermont was amended in the month of December to include pediatric palliative care. So that happened December of 2011. In January of 2012, I was hired to build the program, and I'm really pleased to say that in September of 2012, we started enrolling kids. So we now have, I think, 10 children enrolled in about half of the state where we've launched, and some pretty amazing things have happened on behalf of some family advocates that have really brought this to light, and I'm really honored to be part of it. So let's talk a little specifically about the program now that you understand a little bit about palliative care and then also the legislative process that led to this. And so the program itself it lives over at Department of Vermont Health Access, also known as DVHA or Vermont Medicaid. It's part of the Chronic Care Initiative, which is an initiative that targets some of the highest utilizers within the Medicaid world, those people that really need a lot of support to manage their health and their comorbidities. However, even though we are at DVHA or Vermont Medicaid, we have a very close partnership with Integrated Family Services, especially children with special health needs, which is why I wanted to make sure that Roz was here to work with me. So the takeaway is that for families on the ground on a daily basis, even though we're in different departments, we have a shared mission to make sure that we're bringing all the appropriate support services to families and to kids in the community. And on a day-to-day basis, you shouldn't really know the difference that we're not sitting under the same roof, that we're working that closely together. So who is eligible for palliative care services? I mentioned that this program falls under the Global Commitment Waiver, and so certain things were dictated by that legislative process, and this is part of it. So that's essentially to say that this isn't something that I can modify or change, although I always, take things into advisement, and we always want to make sure that we're meeting needs as best as we can. So who's eligible for the program? Program eligibility is based on a referral. That's done by a physician, a PA, or a nurse practitioner. And the reason that that's done is primarily because we have diagnostic information that needs to be signed off on. And that referral is just a form. That's not to say that a family or a CSHN social worker or someone from Vermont Family Network or a parent can't call me and say, I think that I know a child or my child might really benefit from some of these added support services, and then I can take it up with the pediatrician and we can take it from there. Children need to be under the age of 21. They need to be diagnosed with a life-limiting illness from which they're not expected to live into adulthood. They need to live in Vermont, and they need to have some form of Medicaid. Medicaid does not need to be their primary, but they do need to have some form of Medicaid. Now I want to address that second bullet of diagnosed with a life-limiting illness and not expected to live into adulthood. This is language that we, and I personally have struggled with a lot, because I think that it's a tough box to check or circle to fill in for a parent or for a caregiver or for a pediatric specialist or primary care doctor to say that they don't expect a child to live into adulthood. But we do want to ensure that this program is available for kids that are of the highest need. And so the way that I often explain this to providers, and I'm very honest with families as well, is we use a surprise question. Would you be surprised if this child did not live into adulthood? And if the answer is no, I wouldn't be surprised, then they would very likely benefit from palliative care. It doesn't mean that if a child does live into adulthood that we're disappointed. We're thrilled. The day that I get to disenroll a child for graduating to their 21st birthday will be a wonderful, wonderful day, and I look very forward to it. But it is just to ensure that we're making sure we're working with the right population of kids. And the services that kids can be eligible to receive, and this is based on a needs assessment, are care coordination, family training, expressive therapy, skilled in-home respite, and grief or bereavement counseling. And we're going to go into those services in a little bit so you can understand more. So one thing that I just want to make sure people understand is that not every child who's enrolled in the program is going to get all 5 of those program services to max benefit. And that's not only a capacity issue in terms of our home health agencies actually being able to give all of those services, but also families don't really need all of those services at all times. So there's 2 different eligibility processes. The first is program eligibility, and that's just making sure that that child meets those 4 basic criteria: Vermont Medicaid, their diagnosis, where they live, and their age. And that happens during the referral process from the physician to myself. And the second piece is that service needs assessment that goes, that right now means I go into the home, meet the family, do a needs assessment, talk with them about what their needs are, and find out what of those 5 core services they need at that time. And then we initiate those services, and then over time, as that child's needs might fluctuate, we fluctuate with them. So let's talk about the first service, care coordination. I will sort of preface by saying that all of these services are offered through your local home health agency. So we wanted to use the existing structure that already existed and capitalize on their expertise and the work that they already do in the field. And that was also intentionally done because many of the kids that we're going to be enrolling and have enrolled are already within a home health agency, and so it's a familiar face and familiar people in a familiar institution. And so this care coordinator is a person who is a nurse, and they're intended to be the absolute key person for the family. They maintain communication between the family and the interdisciplinary team. Hopefully they remove some of the burden from the family from having to do the case management for their children. They coordinate lots of services and community supports. They're very knowledgeable about their local resources. And they make sure that everybody who's on the multidisciplinary team is on the same page. One of the ways we've seen care coordinators be really effective is, especially at the time of enrolling a child in the program, we've seen a lot of care conferences happen where the care coordinator meets the family, gets to know them, figures out what the temperature is of things happening, how involved and how knowledgeable all of the other providers within the care team are of the child's situation, and they get them all to sit around the same table for an hour. And it's incredible what can happen in that room in such a short period of time, making sure that everybody is perfectly aware of where the child is in their illness trajectory, what the family's goals are in order to maintain quality of life, etc. So the care coordinator is really the lead person on the team for that child and family. The second service is family training, and this is really educating the family and the caregivers on absolutely anything they need in order to feel empowered to best care for their child at home. It's a rare opportunity that we have the time to have a nurse come into our home and teach us about whatever we need to be taught about in order to best care for our child. So this can be about things like new durable medical equipment. It can be about how do I actually organize a medication administration schedule that I can keep straight in my home. Other ways that we've used the family training service is that if people have, say, unskilled workers in their home caring for their child through different children's services throughout the state, sometimes this nurse can come into the home and help provide some education for those people so that the parents feel like those unskilled people now actually do have a level of supervision and education by a skilled nurse so that they can feel like maybe they can actually leave and run an errand or two while that personal care assistant is in the home caring for their child. So it's really been about anything we need to do in order to make sure that that family feels competent and confident to keep their child at home and care for them at home. And it can be not just about the parents, it can be about anybody who's providing direct care to that child. The third service is expressive therapy, and this is pretty exciting because this is not something that historically has been reimbursed by Medicaid or, to the best of my knowledge, by any other insurer in the state. So expressive therapists are, as defined by the Global Commitment Waiver, art therapists, play therapists, music therapists, or child life specialists. And these are people who, at the heart of their education are therapists, but then they have specialties in different modalities on how to work with children. And from what we've seen in other states that have implemented similar programs, this has probably been the most popular service available for kids because it's in the home, so it's in their own environment. The therapist gets the benefit of getting to see the home environment and work with kids and what is familiar and less scary to them, and also help them work through whatever they've got going on. If they've got a surgical procedure coming up, if they're having a hard time coping with some of the physical changes that might be happening to their body secondary to their illness, these are incredible individuals that are trained to work with kids in different ways. And so, as I said, the types of therapists are child life specialists, art therapists, play therapists, and music therapists. And these people are not nationally licensed, but they are credentialed by their own credentialing boards. And we have a lot of them here in the state of Vermont. Once I started doing some probing, we had a lot. And because they cannot get reimbursed based on their, say, their registered art therapist credential, they often end up going and getting an additional licensed mental health counselor degree in order to practice, and then they use their art therapy modality as part of their practice. So we're very, very blessed and fortunate in Vermont to have a lot of these individuals available that have expressed interest in working with kids enrolled in the program. And then the fourth service is skilled respite. This was really intended to meet the needs of families who, from no other way, would ever get a skilled person in their home to care for their child. I am always impressed by parents that essentially are physicians and child life specialists and nurses all in one, and they've converted their home into a mini hospital, but by virtue of that fact and because they are so competent and confident in caring for their child, they literally never get a break. And so this is a very short-term, a few days per year type service where on an as-needed basis for children that might otherwise require hospitalization, we can get a nurse or an LNA into the home in order to care for children so that caregivers can get a break. And then the final service is family grief counseling. Grief comes in many different hats. At the time of diagnosis, there's grieving the loss of maybe what you pictured your child's future to be like. We see this with diagnoses like asthma, diagnoses like diabetes. You have a baby and you have every reason to believe that their life will be, and I do this quote unquote with bunny ears, normal. And so there's a grief of that. There's a grief and around the loss of that normalcy, and that's totally appropriate. And so this grief counseling isn't just around dying, it's around grieving and any challenges that the family is experiencing around their child's illness. And then, of course, this is a service that, if needed, can continue after a child has passed away, if that in case does end up happening, for up to 6 months after the child's passed away. So this is a person who, again, rides those highs and lows with the family and can be there more or less as needed as time goes along. And so how does this all work? I'm not going to go into this chart in too much depth because I want to give Roz a chance to talk a little bit too. But just so you understand, the first thing that needs to happen is the referral from the physician, and that comes to Department of Vermont Health Access, or really myself, because I'm generally the person determining most of the eligibility in partnership with the Medicaid medical director. Again, that's not to say that a family or someone else can't call me if they think that there might be a child who's eligible, but a referral form does need to end up coming to me with a physician NP or PA signature. And then I assess for program eligibility. If the child's program eligible, then a letter is sent to the family and to the referring provider to let them know, and then I set up a needs assessment with that child. I go into the home, get to meet the family. This is probably the best part of my job, and find out what services within the program, those 5 core services we just reviewed, might be the best fit for the family. Once that's done, everything is done in a prior authorization process. So the family and the referring physician and the home health agency that will be delivering the services all get a letter in the mail that says these are the services that have been authorized for this child, and they're authorized from this date to this date. It's very similar if you've ever gotten a notice of decision for any other services. And then once those services are authorized, then they can be implemented, they can be started. And the care coordinator within the home health agency, who's again the lead on the team, the key person for the family, and we communicate really closely. Especially in this program's infancy, I've been communicating with the care coordinators regularly, sometimes weekly, just to ensure that we're doing what we need to do, that we don't need to fill in any gaps, and make sure that this is going as smoothly as possible, as smoothly as anything can in startup, I should say. And then annually, we do a full needs assessment again. So every family is going to undergo a needs assessment to ensure that we're not missing anything and that they're getting everything that they need. And of course, adjustments can be made in the interim if need be. So how to refer? Again, a physician, NP, or PA must complete a referral form and fax it with appropriate supporting documentation. That may not be necessary, but if I do need more documentation, then I'll let you know. But I encourage you and welcome people to always call me if they have questions. If you've got a child yourself, or you work with a child who you think might benefit from some extra supportive services, I would love to talk about them. And the referral forms can be found on the Vermont Medicaid website for providers, which is listed right there. So I'm going to hand it over to Roz for a minute, and she's going to talk a little bit about Pediatric High Tech.
Good morning, excuse me. Good morning. This is Lavallee. I'm a nurse care coordinator with children with special health needs, and I'm also the lead for Pediatric High Tech Nursing. I'm going to give you a little bit of background. It says previously the Division of Aging and Independent Living, which is DAIL, was the agency that started, or the division that started Pediatric High Tech. And a lot of people remember Gary Boyce, who was the pioneer of high tech. And when he retired, David Ovet took over. And about over a year ago, my director, Steve Brooks, came to me and said, you know, we are seriously considering taking over Pediatric High Tech, and we really feel that children with special health needs should be involved with this. And I absolutely jumped at that chance to be a part of that, because the majority of children who are on Pediatric High Tech are children that we already knew through clinics, through just families calling us in regards to any kind of community service. So these children were known to us. So I was quite excited about that. The other thing is that you know, that we have David and Gary were the only nurses that covered the whole state of Vermont, and we actually have nurses in different offices throughout the state of Vermont that can actually help these families within their community, and I will talk about that later. The clinical assessment to determine the level of care for each child, it's usually the hospital would contact me in regards to a child that's been born with high-tech need, and working with the primary care physician. And what we do is we usually get involved, the VNA, home health agencies, and beyond it, and it's up to the family who decides which agency that they're going to use. So the next part of that is the public-private partnerships providing skilled nursing, doable medical equipment, and care coordination, and that is through the agencies within the community, the VNAs, the home health agencies, and BIATA. Some families, it's up to the family to choose who they're going to use. So what we do is that they make the decision, and then we contact, or the agency's already been contacted to before the child leaves the hospital, so that they know that they have this child coming into within their community. So they need to have nursing educated in how to take care of this child. I'm sorry. The difference between, just so that you know the background, the difference between a VNA and home health nurse or agency is it's nonprofit, and nonprofit, and BIATA is a profit organization. There is no other difference than nursing care. The nursing care is absolutely excellent. They do not send an RN or an LPN to the home unless they're educated in taking care of a child who's technologically dependent, and I need to stress that because that's why a lot of times families have to wait before they discharge their child so that they make sure that they have the nursing care that they need. Who is eligible for PD High Tech? I just need to go back a little about. I'm sorry that people can't hear me. I moved it up. I've got a cold, so anyways, I digress. I just want to just make people aware of why, because I have a lot of people that say to me, "Why is the state getting involved with PD High Tech?" Well, the Department of Health is under the Agency of Human Services, and the whole mission, vision, and I'm paraphrasing here, is that of the health department is to provide all Vermonters appropriate health care, or keeping Vermonters healthy, should I say, making sure that they're safe and making sure that they understand all of the community services and are well informed in that area. So under that is the Division of Maternal Child Health, and because of the Division of Child Health, we are children with special health needs under that. So it makes perfect sense for children with pediatric high tech and children with special health needs to be all under the Division of Maternal Child Health and the Vermont Department of Health. So getting back to who is eligible for pediatric high tech, children who are birthed to 21, children who have Vermont Medicaid and are a Vermont resident, children who meet the medical necessity eligibility. So I want to just say the operative phrase here is home-based care for children. So children who have at least one or preferably two stable, consistent caregivers, and it's either the parent, the guardian, or a family member, neighbor, whoever, will be educated before they leave the hospital on the care of their child. They are the primary care givers, and after that, that's when the VNAs, the home health agencies, and BIATA would get involved with the family. Examples of who is eligible or what is eligible for high tech is children who are completely dependent on respiratory support, and it's mechanical / ventilators, CPAP, which is continuous positive airway, and BiPAP, which is actually a registered name for it. It should be BPAP, but anyways, I'm digressing here. And complex healthcare needs such as an unstable airway. And I just want people to know that we're actually working on better criteria for this, which is actually going to be written down so that people in the community can actually have access to exactly what pediatric high tech is. So who can assess or access children with special health needs? Any child with a special health needs, we are opening it up to everybody. We never provided services for children with severe asthma, diabetes, children with sickle cell anemia, other chronic care problems with children within the state of Vermont, and we are now opening that up to all children with special health needs. We have nurses and social workers that are located in statewide. So what I was earlier I was talking about that we have nurses in different communities. There's Suzanne Linden, who covers Windsor and Windham County, Louise Durr, who covers the Bennington-Rutland area. Sue Offenhartz and myself are out of the Burlington office, and we cover Chittenden County and all the rest of the counties within that were not mentioned. We have social workers that work individually with the nurses so that if there is a problem or a concern, we have access to them and we work as a team. It allows families to have a local nurse or social worker available close to home. who knows their community better than a nurse or social worker that actually lives and works in that community? And that was a big driving force for us to take over, because I know no more what's going on in Brattleboro or Bennington, and it's just so helpful to families to have an objective person that they can call and ask questions if there's a problem or a need. Children with special health needs staff knows all the local communities, which I just said, and the goal is to make life a bit easier for families. It's just so nice to be able to have families be able to call if they have questions or concerns about resources within their community. So that is basically what high-tech nursing is. We're going to take questions from people. I just want to let people know that on the webinar, there is my address, should be my email address and my direct line. I really would appreciate people calling me on my direct line, so that if they have questions about high-tech, they can do that.
So this is Monica again. So like Roz said, we've got about 20 minutes. We would love to address some questions about high tech, to the best of my ability, CSHN, and certainly the Pediatric Palliative Care Program. We've gotten some wonderful questions so far, and by all means, my contact information is also on this last slide, and you are welcome to call me. Same deal as Roz. It doesn't make sense to call anyone else other than myself, so there's my direct phone line. So go ahead and give me a ring. So I've gotten a great question. In which half of the state has this program been launched, and when will this program launch in the rest of the state? So we are live in Chittenden County, Washington County, Windsor, Windham, Orange, Addison, and Rutland and Bennington were just oriented earlier this week. What that means in terms of going live is I work very closely with the agencies prior to launching in their area to ensure that all of the caregivers within their agency are up to speed on the expectations and the roles and responsibilities of each one of the providers for those 5 core services. And on sort of a larger level than that, we started back I think it was September, we did a statewide pediatric LNEC course, which is essentially the gold standard for nursing and the multidisciplinary care team in terms of how to best care for children with palliative care needs. We invited 4 wonderful LNEC trained nurses to come and speak to our community. It was a great start. We had 80 people there, and I'm really committed to keeping educational opportunities like that happening at least on an annual basis, and to do things like this just to make sure that we're spreading the word that this program is available. So I do lots of education sort of on a global level with home health agencies and multidisciplinary providers in the community, but then also each agency and I spend a long day together to make before we get the program up and running and make sure that they're good to go before we launch. And so the plan for the rest of the state is, now that we're open in a little more than half of the state, is to make sure that the counties we've got going are in a good place, and then we can move on to start doing some other counties. So at this time, we're not scheduled to open in any others, but I'm going to be in the process of scheduling with Franklin and Caledonia next, probably within the next month or two. And the goal is that we're launched statewide probably by mid-2013. That would be our goal. Let's see. Oh, we lost the screen. Hold on one second. Another question, do you have a list of the expressive therapists in the state? We are located in Caledonia. Absolutely, I do have that list. Part of my job was early, I guess it was back in April and May, was to network with some of these expressive therapists throughout the state and see not only how many did we have, where were they located within the state, and who had the right credentials, and what's that credentialing process. So I did compile sort of a big list and sent it out via VAHA, who I've been working with really closely, to make sure that all the home health agencies had that list. But by all means, if you need a refresher, if you need an update, I would recommend that you shoot me an email, or I know who wrote this question, so I will be in touch with you. Let's see, another question. do providers like expressive therapists need to be Medicaid providers? So in developing the program, we opted that no, the expressive therapists do not need to be Medicaid providers. We wanted to really promote continuity of care and a closely linked multidisciplinary team. So what's ended up happening is instead of having these expressive therapists function as independent providers, they're actually contracted through the home health agencies. And our hope is that over time we'll have enough kids enrolled in the program that these expressive therapists can be, part-time staff members maybe, but right now they're sort of working as contractors or per diem staff members so that they can really get to know all the benefits of the home health agency. And so that's the way that it's worked. And thus far it's change is challenging, but it's worked. Home health agencies have contracted with some really phenomenally educated expressive therapists, and there was a wonderful turnout from the expressive therapy community at this statewide palliative care training in September. So they also are taking wonderful independent steps to become palliative care experts. Another question is it correct that the CCCR program under the Affordable Care Act allows hospice to be in place while children are still getting curative treatment? That's a wonderful question, and you are correct. The Concurrent Care Act is what the CCCR program stands for, or I think it's Concurrent Care Requirement for children. And what that means is that children who elect the hospice benefit, meaning if they sign up for a hospice program in their area, they can still get curative and life-prolonging treatments. That's absolutely the truth, and that's secondary to the Affordable Care Act. What I will say is that in order to elect the hospice benefit, there still needs to be a determination by a physician that the child will or the individual will die within the next 6 months if the illness takes the course that we expect that it will. And so there's nothing wrong with that. I think it's wonderful that we now have the ability to offer curative and life-prolonging treatments to children in hospice, but it still means that they're not getting the wonderful wraparound supportive services until someone's determined that they're within 6 months of death. And that to me is tragic. And that's really where palliative care stems from. We believe that anybody living with an illness that is serious and potentially life-threatening deserves support throughout their entire life, that it shouldn't just be within the last 6 months of life. Which, let's see. Question for Roz. I thought that to be eligible for high-tech, one needed to have 2 modalities, not just respiratory, and thought it needed to be a trach. I'm going to pass it over to Roz.
That's a really good question, and I probably did not answer this well. There are children who have trachs that do very well, and they do not need to be on high-tech nursing. It usually is, for respiratory, it depends on what it is. If the child is dependent on a ventilator, then they, with CPAP or BiPAP, or with a trach that's vented, yes, definitely they are eligible for high-tech nursing. We do have children who have trachs that do very well, go to school, and even though they need suctioning, they may, anybody can learn to be, learn how to suction. It's medical dependent. So the technological dependent child. So we have to be very careful. And I am going to tell everybody out there is that there's definitely going to be very good, consistent guidelines for people to know, and it's going to be on a website. We're working on that right now. We're trying to get the Children's Personal Care on the Children's Special Health Needs website and along with the high-tech. So families are not just reading something and saying, what does this mean? We want concise information on that. So that was a good question. Thank you.
Great questions. It's Monica again. I wanted to address a wonderful question that was asked. I have a teenager who may be eligible for pediatric palliative care, but I'm afraid to tell her because if she hears palliative, she will think she is dying. What do you suggest? This is, if there is an essence of where my passion is, it is this. Palliative care has historically gotten a really bad rap because it's misunderstood. And what we have seen through years of work, especially with children and families, is that once we sit down and explain to a family Actually, that's very true. A lot of people do think that palliative care is the same as hospice, but that's not the case. Palliative care is an added layer of support for you living with the illness you have. The response from families is really phenomenal. They go, oh, okay, thanks for explaining that. Next, let's, sign me up. I love this idea. It's really the providers in the community, and I say this as a pediatric nurse practitioner because I understand the conundrum here. It's really providers that are scared to bring up palliative care because they're the ones that still don't understand what it is. When we explain it to families, what we see is that families are the one asking for palliative care, not providers. The vast majority of the referrals that I have gotten have been because families have heard from someone else who's been enrolled in the program that it's been great. And that is a testament to the power of families working together and supporting one another. And so it's really just an educational thing. It's just a word. I could call this the supportive program, and who knows, maybe I will break down and end up doing that. But it's just a word. And you can call it rainbows and unicorns, but it's still palliative care. That's what it is. So it's just a name, and I'm open to suggestions to change it, absolutely. But what we have found is that once we educate people in the community, providers and families alike, that becomes less and less of a barrier. And so my recommendation would be, let me meet the family and say, okay, what of these 5 core services do we think could help you? And that's just where we take it, and that's how we start. Another great question would be, for school-aged children in the program, do you involve school personnel? Can you give an example? That's an excellent question. We absolutely do involve the school personnel. I talked a little, to give you an example, I talked a little bit about these care conferences that we hold for some of the kids enrolled. So I think care conferences are a really wonderful thing. I'm sure many of you are familiar with the medical home model, which is becoming more and more popular. And in some of the pediatric practices that are good medical homes, they've been practicing care conferences, they've been doing care conferences on kids with complex needs regularly. In some of those practices that maybe aren't as familiar or aren't as accustomed to doing regular care conferences, our care coordinators from the palliative care program within the home health agencies have sort of gently guided them in how to hold a care conference at their pediatric practice, and that includes the parents and the child if they want to participate, which we love. And so quite often we will, if a child is still in school, we will invite their school nurse or their special educator who's involved in their care and make sure that, again, everybody's on the same page and that we're addressing the needs that we need to in the school. And then there's also a lot of things that we want to ensure that if the child is at some point too sick to go to school, that we want to be addressing and somehow supporting the school and the child's classmates and answering their questions and making sure that they're supported, because grief, spans lots of different people other than just the family. So historically, we have really addressed worked with schools pretty closely. Let's see. Another question. Are there similar programs for children who only have private insurance? How I wish there were. I'm assuming this program is palliative care, directed towards the palliative care program. So at this time, private insurers are not, I should say, robustly reimbursing for palliative care services. Certainly they're not reimbursing for expressive therapy. I know that for certain. But the beauty of this is that we are educating all of the providers statewide on palliative care principles, and we're connecting them with wonderful resources. So if there was a child in a community that for some reason couldn't get Medicaid, then that home health agency still has a lot of knowledge and tools in their toolbox on how to best support that program. But the caveat to that is if a child needs palliative care services, then I'm so closely linked with CSHN, and they seem to be really wonderful at helping me navigate some of the eligibility criteria for Medicaid. So we've had a few children that we've really wanted to enroll in the palliative care program who didn't have Medicaid, and we were able to get them a Katie Beckett waiver, and that's been really best outcome for everybody. Let's see. Are you aware of a similar program in New Hampshire? Sadly, no. I work really closely with the VNA and VNH in particular, and Dartmouth-Hitchcock, because they're a border facility, and we get a lot of referrals from them for the program. And New Hampshire, although ahead of the game in many things, has not implemented a statewide pediatric palliative care program. But that's something we would really like to work on and to support our neighbor in doing that. But I would encourage you to give me a buzz if you want to talk more about that, because that's something that I've been working with them on as well. Another question, can you describe how short-term respite services work in practice? How are smaller agencies able to assure that competent staff are available as needed? It's a great question, and I believe in full disclosure. I can't say how they work in practice because we've actually not authorized or done this service for any child yet. So we're going to have to, again, with startup and new programs, we're going to have to learn a little bit as we go. The devil's in the details, as they say. So theoretically, in the way that it's set up now, is that the care coordinator identified for that child would contact me and say, hopefully I would already know this child's medical condition, but write a written request for respite services for what dates and why this child meets medical necessity of needing a skilled caregiver in the home. This is sort of the beauty of working so closely with children with special health needs, because those criteria might end up being quite similar to the new high-tech criteria. Who knows? But we all kind of have to work together to see what resources are available in the state. And so based on that request, then the services are authorized for those dates requested. In terms of ensuring that it's competent staff available in the home, the staff is provided by that home health agency. So it's either the nurses within the home health agency that do maternal child health, or nurses within the high-tech program, or if we need to work with a different agency that works in that area to fill those hours, then that's what we'll do. Another question: can children qualify if they have both private insurance and Medicaid? Absolutely. You can have primary insurance other than Medicaid. You just need to have some form of Medicaid. And how do pediatricians learn more about this program? Do they support it or have any concerns? I certainly hope they support it. The provider education piece has been moving along. There's a lot of providers in the state. Fortunately, we're not too big a state. So how are providers finding out about the program? I have been really peddling it almost practice to practice. I've also been doing things like presenting at pediatric grand rounds at Fletcher Allen Hospital. I have been meeting with lots of clinical nurse specialists in different practices, working with lots of pediatric subspecialists, and really I think what's ended up happening is, a few champions have sort of been identified throughout the community that have been huge proponents for the program, and what's been amazing is, when one practice has a child or two enrolled in the program and they see that it can be both of benefit to the child and family, but also to the practice, because we're an added layer of support. We're more people to bounce ideas off of, and also to share the burden in caring for that child with complex needs. And so once they we prove our worth within that practice, that right there is really the greatest referral we could possibly ask for. So I continue to meet with pediatric and pediatric providers and subspecialists throughout the state, and it will be an ongoing thing. I got a question. Monica, are you available via email to follow up? Absolutely. My number is on the last contact page, and then my email is really simple. It's my first name, Monica, my dot Ogelby, my last name, and that's at state.vt.us. And if for any reason you're having trouble getting in touch with me, you can always call the Vermont Family Network or call my number right there. Let's see, another question. Is there a cap on how many children and families can be served in this program? There's no cap, and I hope that we never have to cap it. When we initially started building the program, we did all sorts of data polls to find out how many kids we thought would potentially be eligible for palliative care. But it's so much more than just pulling a bunch of ICD-9 codes, which are codes associated with diagnoses. It's much more comprehensive than that, and it's much more child-specific than that. So we are anticipating that there could be anywhere between 175 and 300 children statewide that could be eligible for palliative care. Like I said, we've got about 10 or 11 kids currently enrolled, and we've got a few that are, in the process of completing referrals. So I really hope that this becomes something that spreads and becomes more available throughout the state. Another question, what have you learned from families who are involved in the program, and do they have improvement suggestions? You know, it seems like every day I learn something new. I would say that the greatest thing that we have learned from families is that they know their children more than anybody else, and they know what they need. So regardless of what a needs assessment says when I walk in their door and say, I think you could really benefit from this, it's really been telling to work with these families who have been managing and caring for their children that have complex needs for years and years and years, that have said, we're willing to try new things, but this is really what we need, and how can you help support our needs? And through listening to families and hearing what they have to say, we've really been able to be creative on how to make these services really meet those needs. I would also say one of the other things that I've learned is that just change takes time. And no amount of my bubbliness or energy or sunshine will make things happen overnight. And so patience is a virtue. And, culture change, getting people to understand and embrace palliative care is hard. Getting, imploring VNAs and home health agencies to contract with expressive therapists is a challenge. The home health agencies in the state have been absolutely phenomenal. They have been embracing, they have been welcoming, but it still is a lot of work for them to implement this and get it up and going. And so being patient, being supportive is something that I've learned a lot from both the providers within the community and the families. And I haven't gotten any specific improvement suggestions yet, but I welcome them. Part of family satisfaction, part of palliative care is collecting family satisfaction data. And as we get the program up and running, that's going to be something we're going to start incorporating into our process really soon, I hope. Another question is, what are your biggest challenges in implementing this program? That could be an entirely different webinar. I think, I hate to put them on the line. I would have to say the providers. I hate to say that. Getting pediatric providers to buy in and to believe that palliative care is a good thing is a real challenge. I think that historically pediatricians have been of the mindset that by introducing something like palliative care that they are taking away a family's hope. If I had $1 for every time I called a pediatrician and said, I've heard that this child has been diagnosed with a new mitochondrial disorder, and we're not really sure what their future is going to look like. I'm wondering if we could be of support to them. And a pediatrician responds with, well, no, the family's not there yet. If I had $1 for every time someone said that to me, this program would be independently funded. Providers are frightened that they're taking away hope from families, and what I'm trying to do is help providers understand that there's nowhere to get. The family is always there. Families always need extra support. Families always need help, and that's all this program is. And the reason it exists is because their children just happen to have some extenuating circumstances that are hard. And so I just, the greatest challenge is just getting providers to understand that we're promoting hope, we're reframing hope, we're looking at the family's goals and making sure that we're accomplishing those that we can. So I would say that education is the greatest challenge. Let's see, one last question, and then we might not have time. Do you have a timeline in mind for rolling out the program to other areas of the state? This is something that once we sort of got through the holiday fuzz and we just got Rutland and Bennington up and running earlier this week, I'm really hoping that we can start speaking with, I think Caledonia and Franklin were the next two counties that I had started the dialogue with. So I'm hoping that maybe in the next month or two, and then we can, we strategically started in places where we thought the most resources existed and where we would have the most kids enrolled. And it's kind of turned out to be the same county to county. So we're trying to go where the needs are. So I think I know who asked that question, so I'll be in touch with you about when we would start. And then let's see. I just wanted to say thank you for joining us. Please remember that this webinar will be archived on Vermont Family Network's website at www.vermontfamilynetwork.org. We really appreciate the opportunity to be here. This was a real gift. So don't hesitate to contact Roz or I if you have any more questions. Thanks.